Yeah, I think we are ready to kick off. We have a good number of attendees who have joined us so far. So I'll begin now. Good afternoon, ladies and gentlemen. It's good to have you all join us this afternoon. This is the third webinar in the series of pro-health tax webinars that Nigeria Health Watch has been hosting in the past 2 weeks. As we know, the government of Nigeria recently approved the Finance Act of 2021, and that introduced the excise duty of 10 litres on non-alcoholic beverages, carbonated drinks. So this has been really the genesis of the 3 webinars that we've held over the past 2 weeks. Some of you may have joined us for some of our earlier webinars. First one looked at, does Nigeria need a sugar tax? And the second webinar looked at building a strong advocacy campaign for pro-health taxes. And this afternoon, you've all joined us for the third and final webinar, which looks at really addressing the need for a sugar tax to solve the issue of Ncds in Nigeria. My name is Vivian Hekwazu. I'm the Managing Director of Nigeria Health Watch. We're very fortunate today to have a very distinguished panel of opening speakers, as well as a very distinguished panel of judges, panel of panelists. So really today we are going to focus more digging deep into why we need a pro-health tax in the first place. Nigeria has a rising incidence of NCDs. We have about 11.2 million people alone in Nigeria with diabetes. That's about 1 in 17 adults in Nigeria with NCDs. And so how do we, as a collective, advocate for the need of such pro-health taxes to address the incidence of NCDs? One of our moderator today is Dr. Umar, who is the president of the Nigerian Cancer Society. And we know that this Friday is World Cancer Day, so it's quite opportune that we're hosting this webinar in advance of World Cancer Day. Our very first webinar, we were able to have the privilege of having Dr. Shikafi Bagudu, who was one of the panelists, and she highlighted in great detail the fact that we have severe funding gaps in Nigeria for cancer treatment. And so this year, World Cancer Day really focused on closing the care gaps. And some of them, those care gaps are there because we don't have adequate funding in Nigeria. So pro-health taxes, as introduced in the Finance Act, is one of the ways the government of Nigeria is looking to address the issue of rising NCDs, in addition to bringing in more funding to our health sector, which we all know is very severely underfunded, with a population of about 200 million, with about 5% of our, less than 5% of our budget actually spent on healthcare. That really highlights the critical deficiencies we currently have in funding healthcare. So this afternoon, we aim to provide the data and the evidence with our panelists speaking on diabetes, cancer. And for that reason, we feel that with evidence, we can now push and advocate with that data why we need the pro-health taxes that are going to be introduced. So our opening remarks, we are hoping to have Honorable Dr. Tanko Sununu, the Chairman, House of Representatives, Committee on Health Services, make the opening remarks, as well as Dr. Innocent Uja, the President of Nigerian Medical Association. And both are very important in this discussion about building a strong coalition around why pro-health taxes are an efficient way to bring in more funding into the health sector. Unfortunately, both of them are not currently available to join us, but they will do shortly. I hear they're both in transit. So as soon as they do, then we will welcome them. But we will kick off first with our opening speaker. And today we're very privileged to welcome as the opening speaker, Professor Akino Shupogwun, who is the Chairman, Lagos State Primary Healthcare Board. And he really will provide an overview of sugar taxes. As I mentioned, our moderator today is Dr. Adamu Al-Hassan Umar. He's the President CEO of the Nigerian Cancer Society. So he'll be moderating the panel session. But before we go further, I'd just like to mention a few housekeeping rules. As you will see, you have the chat box. So please feel free to welcome yourselves, drop your name, the organization you're coming from. It's always great to know who's joining us on our webinars every time we host them. But also you'll see the Q&A box where we'd like you to drop your question. And if you can, direct your question to the person you would most like answered. Otherwise, just drop your question either way. So we'll be able to pick up your question during the question and answer session. And feel free, of course, to look through the questions that have been asked previously. And there's a function that you can use to click. There's a hand that points up. If you click on that hand, then the question asked kind of gets pushed up. So in a way, many people may have thought of a similar question. So in that way, able to push certain questions up and make sure that they're answered. So without further ado, I'd just like to welcome you once again, those who've just joined us. Thank you for joining us this afternoon as we conclude our third web series focusing on pro-health taxes. I'd like to welcome Professor Akin Oshubogun from Lagos State Primary Healthcare Board to please give us your opening remarks, and then we'll follow on with the moderated session by Dr. Umar. Thank you.
Vivian, I think Professor Uja, President NMA, is here now.
Okay, so maybe the president of the NMA would like to give his comments before I start.
Apologies, Professor Uja. Good afternoon, sir. Welcome to our panel session. We were told you were in transit, so it's great to have you. So once we hear from your remarks, it's good to hear from the perspective of Nigerian Medical Association on the pro-health taxes. Thank you so much.
Well, thank you very much, and let me say good afternoon to all participants. It's a pity that I'm in transit. I'm in for a burial of one of our past second vice president of Nigerian Medical Association. But I find it very, very important to join this discussion. And I want to first appreciate the organizers of this webinar and on issues of cancer. There's no doubt that it's a great burden to Nigerians and to the general public, and even to us who are medical practitioners, because we face the challenges of prevention, treatment, and care. And we want to use this opportunity to appreciate the president of Nigerian Cancer Society, Dr. Umar. I call him Marafantikau, and all the other members of the team that have made these activities very robust. I am aware that you have paid courtesy visits, advocacy visits, and that is the way to go, because yes, we can advocate, but the policymakers who can appropriate as appropriate, providing facilities for care, prevention, and treatment. I was scheduled to meet with you. Unfortunately, because of my busy schedule, I couldn't, but I apologize for that. All I can say is to continue to encourage us to work very hard so that we can prevent, treat, and care. And of course, we need to advocate for the provision of facilities, modern facilities for care and prevention. We know that in Nigeria particularly, we have not got real equipped designated centers for the treatment of cancers. And we will advocate for this as a Nigerian Medical Association. We've been doing that, and we need to join hands with the Nigerian Cancer Society so that our patients can get the best quality of care. Having said that, I wish all of us well, and I wish my president of the National Program Medical College, Professor Akin Oshubogun, is a very committed member of the Nigerian Medical Association. I wish you all of you happy deliberations. Thank you.
Okay, thank you ever so much, Professor Uja, for your welcome remarks, and welcome. It was great you were able to join us to give your opening remarks. We really look to you and NMA as leaders in advocating for sugar taxes and anything else that will bring adequate funding to the health sector, as well as addressing the growing incidence of NCDs in Nigeria. I'd like to now invite
Hello?
Osibogun, if you're able to give your welcome address. Thank you so much.
All right. Good afternoon, the Director of Nigeria Network. I thank you for inviting me, and it's indeed a privilege to have to share some thoughts with colleagues. I will also like to thank Dr. Rumar, the President of the Nigerian Cancer Society, for making sure that I do not mix up my timetable. He's been very generous in reminding me of the event. Let me also thank my president, the president of the Nigerian Medical Association, for leadership and for his initial remarks. This afternoon, a keynote address is, just to set the tone. So I'll be talking about why we need to pay attention to NCDs and the NCD priorities in Nigeria. I'll also draw attention to the increasing prevalence and then the increasing mortality due to NCDs, and then of course the economic burden, and use all that as a justification for the need for additional resources to control the NCDs, and then as a justification for looking for other sources of funding, and then justify why we need these additional taxes. If I am permitted, I'd like to upload my slide. I recognize that I have 15 minutes, so I'll be jumping through the slides. I will jump through the slides and cognizant of the fact that the panel will do more justice to the details. Why Sub-Saharan Africa needs to pay attention to NCDs? Of course, the increasing prevalence in the region.
Excuse me, are you able to make your slides full screen?
Full screen, okay, great.
Thank you so much.
All right, so
perfect.
Is that better now?
Yes, that's perfect. Everyone can see it clearly.
So
thank you,
the increasing prevalence in the region, I'm sure we'll get more statistics with regards to that. I'll provide some, but I'm sure the panel will provide more statistics on that. And then, of course, the higher age-specific mortality rates in sub-Saharan Africa than in established markets, than in developed countries. In other words, if somebody is to be diabetic in Africa, compared to somebody who is diabetic in America, the person who is diabetic in Nigeria will have died since last year, while the person who is diabetic in America is still living. It's a question of access to care. NCD mortalities in younger age groups in sub-Saharan Africa, I also provide some data to show that NCDs occur in older people in the established market economies, whereas in developing countries, you see NCDs in younger people. So we need to pay attention to these NCDs. NCDs are chronic in nature, therefore they constitute a long-term economic burden, which could be minimized through lower investment, or I didn't want to say cheaper investment in preventive interventions. And data from East Africa already suggests that as much as 40% of all deaths are now currently attributable to NCDs. So the teaching was that the predominant disease problems in developing countries, including Nigeria, were communicable diseases. Yes, they still account for most of the diseases, but now we are seeing an increasing prevalence of non-communicable diseases such as hypertension, diabetes, cardiovascular diseases, and so on. Nigeria is therefore going through an epidemiological transition characterized by a dual epidemic of communicable and non-communicable diseases. And it only makes sense that we begin to look at how we will find the funds to tackle these dual epidemics. The epidemic of non-communicable diseases coming on existing epidemic of communicable diseases. So our priority non-communicable diseases in Nigeria are basically 6: CVDs, cancers, chronic respiratory diseases, diabetes, sickle cell disease, and mental disorders. Globally, they look at 4, but we've added sickle cell disease and mental disorders in Nigeria because they are important to our geographical location. So in 1990-92, we conducted a national survey, and the reported prevalence of about 10% for elevated blood pressure among Nigerians aged 18 to 65. In 2003, under the auspices of the WHO and the Nigerian Health Foundation, I was part of a team that conducted a survey on hypertension in Nigeria, and we found 28%. So we've moved from 10% to 28%, and currently reported prevalence of hypertension in Nigeria in various studies is in the region of 30 to 35%. So clearly, NCDs as typified by hypertension has been on the increase. When we look at the global burden of disease, almost 70% of deaths are due to NCDs globally. But as I mentioned earlier on, in East Africa, we found that 40% of the causes of death are due to non-communicable diseases. So communicable diseases are still prominent in sub-Saharan Africa, but at 40%, we can no longer pretend that non-communicable diseases are not significant. These are just data to back up the burden of disease. In the African region, as in most parts of the developing world, there are still more deaths from communicable diseases than from non-communicable diseases. But the prevalence of NCDs is rising rapidly due to changes in lifestyle and due to environmental exposures. And we'll see that as we go on during the discussion. I'm sure the members of the panel will, of course, provide us with more data on some of these things. If we look at this burden of disease in sub-Saharan Africa, we'll see that it showed that almost 30%, were due to non-communicable. 30% of deaths were due to non-communicable diseases. But of course, that was about 20 years ago, and now the recent data, 2017, 2018 from East Africa, is showing us figures above 40%. And we can see the figures here, published in BMJ Global Health. Of course, it's open access as long as it's not used for commercial purposes. So I borrowed this slide from that particular article. And we can see that 44 to 45% in Rwanda, in Uganda 33, 35 between 2017 and 2020. So obviously, now we are looking at about 40% of deaths in East Africa being attributable to NCDs. The other side of it is that over 80% of cardiovascular and diabetes deaths and almost 90% of deaths from COPD occur in low and middle income countries. In other words, as I mentioned earlier on, when the non-communicable diseases occur in sub-Saharan Africa compared to in Europe or America, the deaths occur more in sub-Saharan Africa because of the issues of access to care. And then, of course, access to care has to do with financing that care. So if you are not financing the care, or you don't have a veritable source of financing the care, then the access to care will be compromised. And we'll see in one of the slides that over 70% of the financing for health services in Nigeria is coming from out-of-pocket expenditure. And out-of-pocket expenditure is not an equitable way to finance any health service. It causes delays because individuals have to debate whether they should put the money on health services or they should put the money on other needs of the family. So that causes delays in access to health services. This slide shows the age-specific mortality, the sex-specific mortality risk, comparing high-income, low-income, middle-income countries and the African region. It is obvious the African region is having double mortality compared with high-income countries as far as NCDs are concerned. This again justifies the need for us to prevent rather than wait for these diseases to occur. In developed countries, 7 out of 10 deaths are in people above 70 years old, whereas in developing countries, only 2 out of 10 above 70 years old. In other words, 8 out of 10 are below 70 years old. So the deaths occur in younger people. Again, a justification for us to save lives, prolong lives, and therefore we need to invest in interventions that can save lives and prolong lives. Well, these are just figures about diabetes, specific diseases. I'm sure that the panel will do justice to that. As I mentioned earlier on, up to 80% of cases of coronary heart disease, for instance, could be avoided through changes in lifestyle. So emphasizing prevention, particularly because we cannot find the resources to fully fund care for most of these non-communicable diseases. We spend far less on health than the established market economies. So these are the risk factors, and therefore an opportunity for us to prevent the diseases. So we can spend more on diseases, but we need to also aggregate the funds to be able to spend the money on diseases. So these diseases affect economic outcomes through mortality and morbidity, affecting labor and resulting in loss of productivity. Deaths and sickness absenteeism from work will reduce productivity. On the other hand, increasing expenditure on treatment and treatment-seeking behavior will also have economic outcomes. And then, of course, opportunity cost. Once the money is spent on diseases, the money will not be available to be spent on other items. These are justifications for us finding the money to prevent non-communicable diseases and to control non-communicable diseases, which implies that we must improve access to care for people affected by non-communicable diseases. So while the cost of treatment may be higher in developed compared to developing countries, cost of accessing treatment may be very high in developing countries. And while CVDs affect older age groups in developed countries, a high percentage of CVDs are occurring below the age of 60 years in developing countries. So, and that implies longer lost years of productivity. Then in the following slides, which I hope the organizers will share with participants, I just present the kind of expenditure that goes into providing healthcare for NCDs in Europe and in South Africa. You can see £7 billion for heart disease, coronary heart disease in the UK, just coronary heart disease alone. So they cost a lot of money. So it may be advisable that we invest more in prevention. And then, of course, in South Africa, almost 25% of total health expenditure is spent on direct cost of CVDs. I already mentioned lost productivity, which surpasses the cost of treatment as the cost of economic burden. Okay, this slide shows how we finance health services in Nigeria. You can see the big orange slice of the pie. That is out of pocket, and that is not the most equitable way of funding health services. It causes delays because individuals have to debate in their minds whether to put the money on health or to put the money on other needs of the family. Therefore, we need to find smarter mechanisms for funding health services that will not require individuals to delay seeking health services. So the rising economic burden of CVDs and current predominant healthcare financing mechanism will further impoverize a large number of Nigerians if urgent attention is not paid to the control and prevention of these diseases. Of course, coronary disease used to be a disease of the affluent, of the rich, but now it is becoming, 50 years later, it is becoming a disease of the lower socioeconomic classes. And therefore, we are not surprised that we are seeing them in some sub-Saharan Africa. So in 2016, I gave an interview to The Lancet, which was published in their volume 4, January 2016 edition, drawing attention for the need to put more funds, because the emergent dual epidemic of communicable and non-communicable diseases was putting, and is still putting, more stress on a suboptimal system. Our system that was not adequately addressing communicable diseases is now saddled with a dual epidemic. Therefore, we need to find the money, and we need to be smart with regards to how we find the money. So we need to therefore adopt smart control financing mechanisms. And while some argue that increased taxes on tobacco, etc., may not necessarily reduce consumption, probably because of the addictive nature of some of these substances, the revenue from taxes will be available to pursue preventive and other interventions. And some of the interventions, of course, will be to provide information on diet, to change behavior change communication, to encourage physical activity, and also provide the facilities. It's not sufficient to just provide information on the need for physical activities. We must provide facilities in our communities where people can engage themselves in physical activity. And then, of course, we must keep on campaigning on the avoidance or cessation of tobacco use and the abuse of alcohol and so on. And then we need to do risk assessment and targeting of specific interventions. And all this require funding. And of course, ensure that we have facilities for early diagnosis and prompt treatment. In conclusion, good health is an investment in economic growth. So there cannot be any economic growth if you don't invest in the health of your people. And to invest in the health of the citizens, we must find smart financing mechanisms that don't depend totally on individual decisions, because individual decisions may slow down or delay access to care. Governments have legitimate authority to levy taxes as long as the proceeds are to be used for the common good. Pro-health taxes for as long as they are properly dedicated. Because I'm sure that we will still be engaging the Honorable Minister of Finance in that conversation. When we do implement these taxes, one will hope that the revenue collected will not be going into one general pool, but will be going into a dedicated pool for health rather than into a general pool. Because if it goes into a general pool, then it will not achieve the purpose for which it was initiated. So when it is into a dedicated pool, it can be used to improve access to preventive, curative, and rehabilitative health services. The other area that we've not sufficiently, sufficiently tapped into is to mandate health insurance. Of course, it's a form of taxation, and it is, in fact, a dedicated tax. Health insurance is a dedicated tax. Although we've not interrogated it in a legal system in Nigeria, in 2012, 26 or 29 states took the federal government of the United States to the Supreme Court to challenge the Affordable Care Act. And the judgment in June of 2012, the judgment of the Supreme Court of the United States was that mandatory health insurance is a form of taxation, and governments have a legitimate authority to levy taxes. The details of how we will implement a mandatory health insurance program is a different thing. It cannot be handled in this keynote address. But the most important thing is that we need to find smart financing mechanisms, including pro-health taxes. And mandatory health insurance is another pro-health tax. That is my argument. And then, of course, taxes and levies on products that have health impacts, like tobacco, like sugar, like alcohol, are also useful ways of getting additional funds to promote health, to prevent disease, and to provide access to care and rehabilitation. I thank you for your attention.
Fantastic. Thank you ever so much, Professor Oshipogun, for really laying out the local evidence and data for why we need a sugar tax and other pro-health taxes in Nigeria. You know, there are some key takeouts, especially highlighting the fact that Nigeria is plagued with both communicable and non-communicable diseases, and the prevalence of non-communicable diseases is increasing. I will now hand over to our moderator, Dr. Umar, who will now invite all the panelists to share their perspective and also to expand on a lot of what Professor Oshipogun has laid out in providing the evidence for why Nigeria needs sugar taxes and other pro-health taxes, and the fact that with the growing incidence of NCDs, more funding to the health sector will be critical to ensure that those who have NCDs receive the quality of care they need. So without further ado, I'd like to invite Dr. Umar, President of Nigeria, to now take over and moderate the panel discussion. Over to you, Professor Dr. Umar. Thank you.
Thank you, thank you, thank you very much. Thank you very much. The Managing Director of Nigeria Health Watch, Mrs. Vivian Ihekwazu, our keynote speaker, Professor Akin Oshipogun, the Executive Secretary, Lagos State Insurance Scheme, and the Executive Director of NCD Alliance Nigeria. Okay, the NMA President is still in the room. My President, the NMA President, and the Vice Chancellor, Federal University of Health Sciences, OTUPO, Professor IAO Uja MNI, our panelists, distinguished personalities, participants at this very impactful webinar, which is the third in the series. You are all welcome. Thank you very much, Prof, for that, very robust highlight of the situation we are in Nigeria. Tapping from one of your last concluding remarks, where you stated that pro-health taxes, for as long as they are properly directed, can be used to improve access to preventive, curative, and rehabilitative health services. This statement reminded me of a quote that followed the second webinar series that took place on the 27th of January. It was a quote by one of the legendary broadcasters in Nigeria, the president and CEO of the International Society for Media and Public Health, Mrs. Moji Makonjola.
Everybody's here.
She said, and I quote, "We must be deliberate about sugar-sweetened beverages taxes and ensure that the funds are used for the provision of quality healthcare services in Nigeria." He said the Nigerian media should be at the forefront of propagating the information about the sugar tax, track the funds to ensure that they are used to improve the health outcomes of Nigeria. This was a statement made by Moji Mokonjola on the 27th day of January. It has gone to show that the presentation by Prof, the alarming statistics, the high level of mortality, about 28% due to non-communicable diseases, the cumulative prevalence of non-communicable diseases is truly a cause for concern. Now, in today's conversation, we have 4 distinguished panelists who are all here with us today, and they are going to talk around the subject matter. We have a professor of pathology, the immediate past president of the Nigerian Cancer Society, a member of the NCD Alliance Nigeria's board, Professor Sani Abubakar Malami, he's here with us today, We have the erudite Pinky Prof, as we popularly called her, a professor of radiation oncology at the University of Nigeria Teaching Hospital, and the founder of Breast Without Spot, Professor Ifeoma Okoye, is equally with us in this room today. We have the president of the Diabetic Association of Nigeria and a consultant diabetologist with the University of Abubakar Tafawa Balewa University, Bauchi. Dr. Mohammed Al-Ali Dambam is also here with us today. And last but not the least, we have the Director of Public Health from the Federal Ministry of Health, Dr. Mrs. Alice Oko, who are going to do justice to the issues, to the matter that was just presented by Professor Oshubogun in his keynote address. Time may be a factor, but we are going to be straight to the point. And in 4 to 5 minutes, each of the panelists will tell us his take on a line item I have itemized as a lead to the discussion. So without much ado, I thank you very much for this opportunity to moderate this panel discussion, and I welcome you all to the third webinar in the series. I sincerely wish to appreciate the NMA president for finding it worthy, despite the fact that he's on transit, to attend the burial of one of our past vice presidents of the NMA. We thank you, sir. Let me start with Professor Ifeoma Okoye, the Pinky Prof. If you are listening to me. In previous webinars in this series, the two we had over the past 2 weeks, those who oppose the imposition of sugar tax, that is the pro-health taxes that Prof just talked about, have suggested that the link between excess sugar consumption, obesity, diabetes, and other non-communicable diseases may be overstated, or in some cases, even untrue. Prof, can you please shed light on the scientific basis for the association between sugar consumption and these non-communicable diseases that we're talking about? Over to you, Prof.
Thank you. Good afternoon, everybody. All protocols observed. Definitely my own conviction, personal conviction, has been the drivers for obesity, diabetes, and all non-communicable diseases are based on lifestyle issues that are able to stimulate inflammation. And what they do is to increase the free radicals that you have, and in excess of the antioxidants you were able to intake because of poor lifestyle attitudes, lack of exercise, and lack of taking vegetables and fruits in adequate quantities. And it will stimulate the inflammation that is basically the culprit and the underlying reason for most of the non-communicable diseases. Soft drinks, for instance, contain very dangerous chemicals. Though both adults and children find it very delicious, soft drinks have been described to be like villains that rob us of our good health and can result in obesity and diabetes, and even mental health and dental caries. So a little can of or bottle of soft drink can cause so much havoc on our health and the health of our children, because soft drink is a mixture of phosphoric acid, high sugar, caffeine, coloring, and flavors. Moreover, soft drinks are empty calories with no nutritional content whatsoever. And the pH of soft drink, which is 2.5, is equal to the pH of vinegar. And we know how acid that is. So an acid environment actually sustains a lot of carcinogenic activity. A soft drink, no matter the brand, is the most acidic beverage you can buy with your money. So we need to have information go around and have people know this. It is a problem because acid oxidosis comes in contact with soft drinks, increases the risk of obesity by 1.6 times. And the relationship between soft drink and body weight is so strong that researchers calculated that for every additional soft drink consumption, the risk of obesity is increased by 1.6 times. children who consume soft drinks regularly display fractures 3 to 4 times than children who do not. And we know that obesity in children, the fat that is laid in down is very, very difficult to take out later on. So it can also affect mental health of children negatively, especially attention deficit and hyperactivity disorder. And sugar intoxication has been likened to addictive effects such as cocaine can cause. So other children's mental disorders that has been associated with depression, associated with withdrawal and oppositional defiant disorder and conduct disorder. So 1 liter of aspartame, which some people think is preferable to the sugar sweetened beverage, can produce about 56 milligrams of methanol. When methanol is released into the bloodstream, it poisons the body. And aspartame has also been proved to have carcinogenic effects. So, despite all the so-called high-quality randomized systematic reviews that seem to suggest that it is like looking at the elephant, legendary looking at the elephant, that whatever part you touch gives you a perception of what is happening, and that the linkage of sugar, sugar-laden drinks to obesity and therefore to NCDs is not substantiated. But we do know that this raging controversy leaves room for conjecture on the true picture of the entire elephant as concerns sweeteners and health, rather than concluding that the health effects are due to a single component. Everybody's looking at it holistically, and the fact that it triggers inflammation. So added sugars are among the most controversial and hotly debated topics in all of nutrition. And literature is virtually replete with so much documentation that consumption of added sugars has been associated with increased risk of obesity, as well as increased risk factors for cardiovascular disease. And you know that when you dispose a child to obesity in childhood, that child is disposed to cardiovascular disease later on, like including dyslipidemia, elevated blood sugar, non-alcoholic fatty liver disease, and even cognitive decline and cancer. So data to support these assertions, however, have been challenged consistently. Often these assertions have been based on research trials which provide added sugars in dosages well above typically found in human consumption. So I want to end here and see if maybe I will have room for further contributions. Thank you.
Thank you very much, Prof. Thank you very much. Prof has deposited very concentrated stuff that is backed by scientific evidence. We thank you so much, Prof. And this is the reason why for us in the National Action for Sugar Reduction, we are not only advocating for judicious use of these revenues that will be accrued from these tax, but for lifestyle modifications, lifestyle changes that will bring about reduction in the consumption of sugar. So I thank you very much, Prof. My next question will be to my predecessor, the immediate past president of the Nigerian Cancer Society, who is equally a member of the board of NCD Alliance Nigeria, Professor Sani Abubakar Malami. I don't know whether he's in the room. Yes, I think he is. Prof, let me say this. In the presentation by Professor Oshubogun, we discovered that the prevalence rate of non-communicable diseases is estimated to account for about 28% of all mortalities in Nigeria. Whilst we still have the mindset that communicable diseases are still the majority contributor to mortality in Nigeria, but of course, with the statistics as displayed by Prof, the incidence and prevalence of non-communicable diseases is still rising and projected to continue to do so. Sir, why is this shift of concern to Nigeria? Over to you, sir.
Thank you very much, my president. And I want to thank especially the Nigeria Health Watch for organizing this very important webinar at this moment in time when a lot of attention is shifting to issues of healthcare financing and contemporary matters which are relevant to the Nigerian situation, especially the issue of non-communicable diseases. I'd also like to acknowledge and applaud my teacher, Professor Shibugun, for his presentation, which was rather short by any standard. He is the best person to address this topic, and I believe he has done justice to the topic. What the moderator is referring to has been called the epidemiological transition, or what is the epidemiological transition theory, which aims to describe changes in epidemiological scenarios at the global and national level. The assumption is that the shift from infectious diseases to non-communicable diseases underlies these epidemiological trends. In my opinion, and I believe also in the opinion of many authors in Nigeria, including our very distinguished and erudite guest speaker, this theory has failed to describe the true epidemiological situation in Nigeria. Because what we have in Nigeria occurring is a rapid demographic change with dramatic growth of the population. According to the data available, NCDs are increasing in Nigeria, there's no doubt about it. But there is also a predominance of infectious diseases. This has been called a double burden of disease model. This obtains not only in Nigeria, but in a few other developing countries as well. Some have also referred to this as a double jeopardy, because of course, as we know, the health systems in these countries are ill-equipped to respond to these challenges. Funding, healthcare financing is much more of a problem in this context than in developing contexts. So what we are witnessing here is not just a transition to the non-communicable diseases, but then a persistence of old infectious diseases, which had been a problem for several centuries. Some are emerging, and then there are also new diseases, infectious diseases, most especially nowadays we talk about the COVID-19. And so this presents an extraordinary opportunity. So talking about the epidemiological transition, this was proposed by somebody called Omran in 1971, which is over 50 years ago, where he studied the situation in 4 countries, in the United Kingdom, in Japan, in Ceylon, and Chile. Most authors now agree that, and there have been a lot of arguments and counter-arguments in support of the epidemiological transition model. Some against and very many, some for and very many against it. Omron in his own 1971, and to be fair to him, he had revised the model a number of times. He identified 3 phases of disease transition. Epidemiological transition. The first, he titled it as the age of pestilence and famine. The second phase, he titled it as the age of receding pandemics, that is infections. And then the third and the final, titled it as the age of degenerative and man-made diseases, otherwise the non-communicable diseases. As I said earlier, Omran had updated this, and a lot of other people also have argued for and against this. So what we have in Nigeria is a totally different pattern, in the sense that it does not conform or fit into what is expected as the third phase. We have the NCDs, which are increasing by the day, which are challenging health system by the day. And then we have the infectious diseases right there, also increasing. And very high fertility rate, which is compounding the whole scenario. And so I believe this should be a matter of concern because the funding, the planning situation is compounded by these realities on the ground, and as well as the challenges in the ability of the health system in terms of the skilled personnel, in terms of its resilience, in terms of the political will, particularly in Nigeria, to respond to these ever present challenges. So in conclusion, I would like to say that this is a real and present threat, and consequently, all advise that health funding focusing on infectious diseases, which is unfortunately or fortunately, depends on the way you want to look at it, is the reality on ground in Nigeria, should also take into account the concomitant epidemiological scenario and try to encompass the challenges of the NCDs. Thank you very much.
Thank you very much, Prof, for the extensive literature review as regards emerging and re-emerging infections, as regards non-communicable diseases. In all, we still come back to the same issue of funding for preventive measures, funding for research, and funding for treatment. And this is one area that we will not be tired of emphasizing. As advocates, we will continue to engage government, we will continue to engage key critical stakeholders so that the needful can be done. The statistics may be scary, but we remain optimistic, and by the grace of God, we are going to surmount it. I am leaving the executive arm of government for the last, the Director of Public Health, and I will go to the next advocate in line, that is the President of the Diabetic Association of Nigeria. I can see the chat room has been quite busy. There are lots and lots of comments, lots of commendation to Nigeria Health Watch and partners that are organizing this webinar series. We have seen communication from the diaspora, and back home here in Nigeria, we have seen individuals that have been attesting from other African countries, individuals that are passionate about the cause of cancer and non-communicable diseases care in Nigeria. The Q&A section, please, if you have any question from the panelists, for the panelists to answer, kindly drop it under the Q&A section so that the organizers of this program will sort out and determine which ones to answer by text and which ones to direct at the appropriate person to speak to it. Thank you very much. Dr. Mohammed Al-Ali Dambam, the president of the Diabetic Association of Nigeria, DAN, a major partner in the coalition of National Action for Sugar Reduction. Sir, if you are with me, the government has stated that these taxes, the pro-health taxes, will be used for health and other critical expenditures in line with the federal government of Nigeria priority areas. Sir, given that the cost and associated challenges of treating non-communicable diseases such as diabetes, what will you consider, sir, as priority areas for the additional revenue to be channeled towards? Sir, let me also add this. Can you be able to share with us any comparative cost data for preventing versus treating diabetes or any other non-communicable diseases on an estimated cost per person basis? So I don't know whether my long English is making sense. Over to you, sir. Dr. Al-Ali.
Okay, thank you very much, the moderator. Please, I want to seek your indulgence. My network seems to be a little unstable, so I will not use the picture so that you get me. I think the important thing is that there are two perceptions of the government in terms of this tax. One is the revenue aspect, and the other one is the aspect of improving finances for healthcare, particularly the NCDs. And I think if we want to get things correctly, planning is very important in the sense that even before this tax starts accruing, there is a need to define what is to be done and what is for what. I would recommend that at least 60% of that revenue should be kept for enhancing the NCD finances, which is very important. And I think the position should be backed by appropriate legislation so that we don't run into problem when money starts accruing, what to do with it and how to go about who will take what and what. And I think in arriving at defining what is to be done by that percentage for the NCDs, appropriate stakeholders should be engaged. Not only the technocrats in the ministries and other government agencies, but I think the experts in the field, the patient-centered organizations and other civil society organizations will be involved in defining this, what is to be done with this money. And I think one of the key, my own suggestion is that emphasis should be given to prevention, in the sense that if you take diabetes, for example, according to the IDF, up to 2/3 of the people who have diabetes in Nigeria do not even know they have the disease. And most often they present with complications. So, and what are the issues related to this? How do you do the prevention? You disseminate information, knowledge, and do massive screening. Then another important aspect is that we have to look at capacity building for our health workers. There are a lot of gaps in our management. If we see the quantum of the NCDs in Nigeria, it should not be left to the specialists alone. The numbers are too many. We have to look at what areas that relevant task shifting should be done so that we'll be able to catch as many as possible. And of course, we know issues of access to drugs and treatment are very difficult. We should encourage and even support local production of the drugs we consume and commodities for management of the diseases. If you look at it, most of our issues, the drugs are imported. It's very sad to say that of all the years that Nigeria has been in existence, we cannot manufacture even insulin syringe locally in Nigeria, not to talk of the insulin itself. And so we're making ourselves vulnerable. It makes a lot of economic sense to encourage manufacturing. And of course, before that is done, at least a lot of subsidies should be done to people living with the disease. And of course, research is key. If you look at Nigeria now, the last step survey that was done was over 20 years ago. Most of our research are mainly based on local studies. So our figures do not have national acceptability because they are not the standard step survey. I think issue of research should be done. And I think we should also consider having specialized hospitals that manage NCDs, that will specialize in management of NCDs. And when we say management of NCDs, we're not talking, if we say diabetes, we're not talking of where people with simple diabetes can go and get treated. That's not what we're talking about. If we know the various aspects of complications that can occur, like including issues of organ transplant and massive research, these are the types of national centers we're talking about. If you say national cancer, we don't have a national cancer center, but we have many centers that do maybe chemotherapy, radiotherapy. But we're looking at a one-stop center where if people have real issues that are complicated, that cannot be managed in our other institutions, we don't need to go out. We need to discourage medical tourism. People can go there and access services. And of course, even our current tertiary institutions, they need part of the fund to be used in upgrading their facilities so that they can be better equipped to absorb the increasing number of patients, of people with NCD. And of course, whether we like it or not, we need to create a means of empowering people with NCDs so that they are encouraged. For example, if somebody has a limb amputation and he has NCDs, there has to be a means of empowering them so that they can also, most of them are breadwinners, they can continue with their means of livelihood. In terms of comparative between treatment,
Hello, sir, are you there? Hello, Mrs. Vivian, can you hear me?
I can hear you, Dr. Umar.
Is it that we have some little issues with Dr. Alkalis?
I think we might have lost him. Perhaps.
Okay, he's back.
And in Nigeria, but we know in the US, it costs about per annum to manage simple diabetes. Take the fact based on the presentation, if we are able to now encourage if we are able to now have a situation where the cost of management will be low. If we are talking of preventive, you don't need to spend too much to do prevention. Massive screening, public enlightenment, and then you'll be able to do what is called preventive prevention, in the sense that even before complications, you catch people. In diabetes, you can catch people at pre-diabetic state. And if you do that, it will stop you from having the full disease. It will stop you from having the complications of the disease. But once complications come in most instances, management of the complications are much more expensive than even the main disease itself. And that is why we need to spend so much attention on prevention as a priority. So I think in summary, in my submission is that there is need for a lot of planning, and there is a need for involvement of all relevant stakeholders to define the priorities, and it should be backed by legislation. Thank you very much.
Thank you very much, Dr. Alkali, for this wonderful narrative. Prevention, they say, is better, cheaper, and safer than cure. And from your deposition, sir, you clearly highlighted the fact that over 2/3 of patients that come down with diabetes mellitus are not even aware that they have diabetes until they present to the hospital with complication. And this is the reason why the call for the reduction in consumption of sugary substances is very important. This is the reason why the call for increased funding, particularly to the preventive aspect of care, is very critical, because there are a lot of gaps that are bedeviling the Nigeria's health system. So we thank you so much, sir. If you have any question for Dr. Alkali, kindly click on the Q&A component, the Q&A section, and type in your message. Let me quickly go to the Federal Ministry of Health. If we still have Dr. Mrs. Alice Oko, the Director of Public Health, Federal Ministry of Health. Ma, this question is to you now. Nigeria is a country that has a lot of beautiful policy documents. Policy implementation is still a major headache. Ma, the Nigerian National Multi-Sectoral Plan for the Prevention and Control of Non-Communicable Diseases, 2019 to 2025, identifies 4 major behavioral risk factors for non-communicable diseases. And these include tobacco use, harmful use of alcohol, physical inactivity, and unhealthy diet. Of course, including consumption of high sugars. Ma, can you brief us on the progress of these identified priority areas and how the use of physical policies such as the excise taxes complement preventive actions on these identified non-communicable disease risk factors? Ma, if you are still in the room, kindly.
Thank you very much, Dr. Omar. I'm still in the room, but I keep having signs popping up saying my bandwidth is low. So if you don't mind, I would need to speak off camera.
Please
so thank you.
Ma.
Good afternoon, everyone. Please permit me to align with already well established protocols. So with respect to addressing the 4 major NCDs, which are the behavioral risk factors of tobacco use, harmful use of alcohol, physical inactivity, and unhealthy diet, let me start with progress on tobacco control interventions. So perhaps, I hope I'll have enough time, but you could look at that before the plan was made and after the plan was put together. So before the plan was put together, you know, we had legislation for the Tobacco Control Decree of 1990, and this was converted to the Tobacco Control Act of 1990. And then between then and 2005, just like you said, there wasn't much happening. But then in 2004 to 2005, Nigeria signed and ratified the WHO Framework Convention on Tobacco Control. And to domesticate this, the National Tobacco Control Act was enacted in 2015. And in line with the provisions of the NTC Act, the Federal Ministry of Health inaugurated the National Tobacco Control Committee, NATOC, in 2016, and then created the National Tobacco Control Unit in 2017 as part of critical steps for tobacco control coordination. So between NATOC and the control unit, a technical working group on tobacco taxation was established in 2017. And following consultation with various sectors, including engagement with the National Tax Authority and the National Assembly to introduce appropriate taxes, a 3-year excise tax regime for cigarettes and alcohol at an annual incremental rate from an effective date of 4th June 2018 was put in place. Now, so we've had legislation and we've had the taxes, the tobacco taxes and the alcohol taxes. And so now we're also working with, collaborating with stakeholders to implement the Empower strategy, which involves monitoring tobacco use and prevention policies. And the Global Adult Tobacco Survey was conducted in 2012. There's a plan to conduct another one. And to give effect to the WHO FCTC, when the Global Adult Tobacco Survey was conducted, that made Nigeria the first country in sub-Saharan Africa to achieve this. And then protecting persons from exposure to tobacco smoke, offering help to quit tobacco. We're in the process of establishing a toll-free tobacco cessation services call center, and warning about the dangers of tobacco use. There's ongoing awareness creation, and the implementation of graphic health warning messages on packages of tobacco products has commenced. And enforcing bans on tobacco advertising, promotion, and sponsorship. We're collaborating with national media, and this is an ongoing process. And of course, raising taxes on tobacco. There are ongoing efforts to further raise excise tax in compliance with global best practices. Now, with respect to the control of harmful use of alcohol, with regards to the plan, it was to develop a national alcohol policy. I'm glad to say this has been done in collaboration with stakeholders. It's been finalized and validated. And this policy seeks to ensure effective regulation of the production, distribution, and supply of alcohol in Nigeria, ensure effective control of access and availability of alcohol, ensure effective control of consumption of alcohol beverages that are produced both formally and informally, including promoting surveillance, monitoring, and research into the harmful use of alcohol. With respect to promotion of physical activity, the ministry is collaborating through the National NCD Multi-Sectoral Coordination Platform with line ministries, especially the Ministry of Education, to ensure school programs include quality physical education, availability of adequate facilities and programs to support physical activity. And also in collaboration with Federal Ministry of Works and Housing, looking at incorporating core elements of residential density, into building building areas, sidewalks, to facilitate walking and support cycling. And in collaboration with the head of the civil service of the Federation, also through the multi-sectoral coordinating platforms of the national NCD plan, is to ensure all government ministries, departments, and agencies institutionalize sporting activities. I do know that about now we will be having the national sports doctors sports competition or something. And then with respect to the promotion of healthy diet, again, we're collaborating with various stakeholders to ensure implementation of the WHO shake and replace technical packages to reduce salt intake and replace trans fats and saturated fats with unsaturated fats through reformulation, labeling, and fiscal policies. And there's also in collaboration with Family Health to promote, protect, and support exclusive breastfeeding. And of course, we know that we now have the Sugar Sweetened Beverages tax in place, which is a landmark step in an attempt to reduce the demand of sugar sweetened beverages to discourage and reduce obesity. Now, with respect to your second question about how the use of fiscal policies such as the excise taxes complement preventive actions on these identified risk factors, let me digress a bit to say that the good news is that one of the speakers had said that we don't have recent data for Nigeria. The good news is that the ministry is at an advanced stage of conducting a national STEPS survey to determine the actual prevalence of these risk factors in Nigeria. So with respect to the to public health, these excise taxes, they become effective tools to control behavioral risk factors. They reduce demand and consumption of and including exposure to these harmful products. And so that will prompt people to switch to healthier alternatives. Of course, there's the issue of increasing revenue base for government and the earmarking that we've been talking about. I want to say that the ministry has an ongoing conversation with the Ministry of Finance with respect to this. And of course, funding the implementation of the multi-sectoral action plan of the strategic objectives. We're hoping that also these taxes will also be used to do that. In general, we know that it will boost economic development through a healthier workforce, and it will significantly reduce the NCD burden. We've said that. And it will provide sustainable financial mechanisms for the health system in general, because taxes raised from sugary drinks and tobacco will in general allow the Ministry of Health to have more funds for the system. So we have Nigerians with healthier lives, in general, a healthier population and a wealthier treasury. And of course, last but not the least, we know that the health taxes can be used as tools to attain the SDGs. You're looking at goal 3, goals 1, 5, 10, and goal 8, and all of that. So, I mean, I hope this has made a case for pro-health taxes and what the money will be used for.
Thank you.
So I'm here for questions that may follow. Thank you.
Thank you very much, Director of Public Health, Federal Ministry of Health. Truly, you came loaded to this webinar, and we must appreciate you, for all the data that you have deposited on the floor today, and the optimism that you have in ensuring that policies do work, and policies are already working. And as advocates, it is our responsibility to continue to engage you and other relevant government agencies to ensure that we implement these beautiful policies that we have. You made mention of the NMA Doctors Games. I was looking around the panelist room to see if the president of the Nigerian Cancer, the Nigerian Medical Association, my president with a big P, whether he is still in the room, because NMA over the years has been championing the cause of healthy lifestyle for all Nigerians, has been championing the reduction of harmful practices in terms of diet and nutrition that are detrimental to health sector. The NMA Doctors Games that will start on the 7th of February is the 6th in the series, and it has been beautiful from the state level to the zonal level up to the national level, where all zones will come consisting of teams from all the states to compete in different variety of sports. And I must commend NMA for that. Unfortunately, the president of NMA is not in the room, I think. So there is no cause for alarm. We have about 11 minutes to the end of this webinar. And I think at this juncture, I would want to thank immensely our team of panelists and of course, the keynote speaker for doing justice to this topic. It may be the last in this series, but I promise you, many more engagements, many more conversations like this will come up. And at this point, with the last 10 minutes remaining, I think I will hand over to the engine room, the Nigeria Health Watch, so that they can take us through the questions that are lined up for our panelists. And of course, at the end, give us some closing remarks and vote of thanks before we finally call it a day. So Mrs. Vivian Ihepazu, if you are still here, kindly take over from me. I have been bombarded with a lot of stuff, concentrated stuff, so to speak. In fact, I will have to go back and listen to the recording of this conversation all over again to be able to take notes appropriately. I thank you so much, Professor Malami, Professor Ifoma Okoye, Dr. Mrs. Alice Oko, and my teacher, Dr. Alkali Muhammad. I truly appreciate you so much. And the very humble Prof. Professor Shubogu, for your simplicity, your approachability, and above all, your humility, sir. We thank you so much. So over to you, Ma.
Thank you ever so much, Dr. Umar, for brilliantly moderating that session. I have to say that your energy is really infectious. And I think that energy really speaks to the fact that NCDs are a growing challenge in Nigeria. And our panelists were able to outline not just why we need the pro-health tax, but also provide the data, the evidence. So when we hear counter arguments for the need for pro-health taxes, I think the amount of data and evidence from these experts in the various fields has outlined critically why Nigeria needs pro-health taxes and such policies to ensure we have adequate funding for treatment, adequate funding, because most of our funding for healthcare is out of pocket. We need adequate funding for preventative healthcare. So we're not just focusing on curative. So when people present with hypertension, diabetes, we're not just paying for treatment, but we're also paying for preventative programs, as Dr. Oko was able to outline. So we're just going to maybe conclude now with a few questions that were dropped in the chat box. I think the questions really speak to the diverse questions that a lot of the panelists have. And I hope that our panelists can shed some more light on the questions, some of the issues that were raised. So I'll start off by the very first question, and I think it's very pertinent, especially in advent of COVID-19, where we were all stuck at home and healthcare services were severely interrupted. And we've really seen the growth of digital and telemedicine. So the first question really is from one of our delegates, who I must say we're quite happy to have today. He's from our diaspora, Professor Rotimi Jaishimi. It was very, very good to have you join us this afternoon. His question really focuses on the role of digital health and telemedicine in order to screen and reach hard to reach communities and patients, especially in our rural areas where we know healthcare services are not optimal. So perhaps I will direct this very first question I think possibly to Dr. Alex Oko, because we know Ministry of Health, with the growth of digital technology, not just looking at NCDs, how can we really integrate more digital health and telemedicine solutions in reaching hard to reach patients, especially in preventing NCDs? So over to you, Ma.
Thank you very much. I just put in the chat box that we also have a national NCD policy for a national policy for NCD prevention and control. So, I mean, the issue of digitalization or digital solutions is a work in progress, and we will work towards incorporating that into the ongoing strategies. Let me say that NCD prevention and control strategies are also now being incorporated into the primary healthcare level services, and also there's a task shifting and task sharing policy, which also now has NCDs incorporated into that. So I believe the digital solutions will come. It's a work in progress and will continue in that direction. Thank you.
Thank you so much, Dr. Oko, for that. I think we're speaking about the need for digital solutions across other aspects of healthcare delivery, especially when, you know, this can be an effective way of mitigating hard to reach communities, not having health workers there, but also in terms of cost efficiencies in reaching more people when we integrate digital solutions into quality of care for patients. I'll ask the next question. This is from Oladimeji Abalode. Thank you so much for your question. And his question is really talking about more data. So when will Nigeria conduct a national epidemiological survey for key NCDs, diabetes, hypertension, cancer, to inform appropriate planning and funding? I think this is an opportune question, as you know, we heard quite a lot of statistics about the prevalence of these various NCDs. So perhaps I can direct that question to the president of the National Diabetes Association, Dr. Alkali. Perhaps you can tackle that question on surveys that look at key NCDs, diabetes, hypertension, cancers, etc. Where are the data gaps that we need to address so that we're able to ensure that funding is adequately channeled to these different NCDs as and when funding may become available, more funding may become available. Over to you, Dr. Alkali.
Thank you very much. I think this question has been partly answered by the director from the Federal Ministry of Health. But the key issue is that it's something we've been pushing for quite some years now. And it is a key requirement for assessing the health performance of most countries, the issue of the step survey. And you have a more reliable data. And from what we are understanding, maybe anytime this year it may happen. But I think it is important that we continue to push for such a thing to happen because it will change our narrative and will be more scientific in our planning and implementation of whatever policies. And it also empowers on why it is spending so much on something, because it is all about rationalizing spending. And even if they are going to partners, they have more reliable data to really market with and showcase the true situation in the country. Yes.
Okay.
Thank you.
Okay, thank you very much. I think we're coming up to, we have a few more questions which are in the Q&A. I see that our panelists are obliging by answering some of them live. So because we're coming up to 3:30, what I think I may do, first of all, is of course to once again, standing on existing protocols, but to thank all our speakers. We are very privileged to have had a very distinguished panel of speakers with Professor Oshipogun really laying out the foundation of why we need a sugar tax and providing that data and evidence for it. And then, of course, our moderator, Dr. Umar, thank you so much, from the Nigerian Cancer Association. Thank you very much for moderating that session, as well as all the panelists who joined us this afternoon, Professor Ifeoma Okoye, Dr. Alex Oko, Professor Abubakar Salami, and of course, Dr. Al Kelly. Thank you so much again for taking the time out to speak to us this afternoon. So in summary, just to round up, I'd like to please invite Dr. Kunala, Senior Health Specialist at the World Bank, to really round up the genesis of these 3 webinar sessions we've had over the past 2 weeks. We kicked off last Tuesday, and I think some of you were able to join us by looking at whether does Nigeria need a sugar tax? And that really laid the foundation of the Finance Act of 2021 that instituted this excise duty, and that provided lots of evidence and reasoning for why the pro-health tax was brought in place in the first instance. And then, building a strong advocacy campaign for sugar taxes in Nigeria. I think it's all well and good for us to discuss this afternoon the evidence, the data for pro-health taxes, but we also need to build a strong advocacy campaign to explain to wider consumers who may hear counter arguments as to why we are now having a tax put on sugar-sweetened beverages. And in the advocacy campaign, the media really, as the 4th pillar of democracy in Nigeria, is really there to lay out the evidence and also to advocate and push out all of the messaging, to explain to Nigerians the reasoning for putting in place policies where we can have increased funding in the health sector, and also the growing incidence of Ncds, as our panelists and speakers have outlined this afternoon. So that evidence base is really critical in providing the data and evidence for pro-health taxes, not just on sugar-sweetened beverages, but on alcoholic drinks, etc., that do not have any nutritional benefits for Nigerians. So I'd like to hand over to Dr. Kunala just to really summarize, because the discussions continue beyond today, and we all have to be critical advocates for pro-health taxes, etc., and such policies that are in place to improve the health of Nigerians. So Dr. Kunala, thank you ever so much for stepping in to provide this summary, really just to round up the 3 webinars that we've had so far. And thank you to everybody who has joined us so far over the past 3 webinars. Over to you, Dr. Kunala. Thank you very much.
Thank you, Vivian, and I hope you can hear me clear. Like you mentioned, the rationale for these 3 webinars was really based on the kind of pushback we got from industry. If you recall, and as everyone on this call is aware, industry is very well oiled. They have a lot of resources behind them. So when the Federal Ministry of Finance, the government of Nigeria, introduced the Sugar Sweetened Beverages tax, there was a big pushback by industry. And there was a need by stakeholders like the National Action on Sugar Reduction, the Healthcare Federation of Nigeria Health, people to come together to say, well, this thing is really needed. And this is what the 3 webinars have done over the course of the last 2 weeks. But like you mentioned, the discussion cannot just stop with just this last webinar. It needs to continue. But some reflection over these last 3 webinars. Recall, we had the Minister of State last week who opened the first webinar. We had a major private sector player, Mr. Fola Adeola. And up till today, with the presentation by Professor Oshipogun, everybody has been saying the same thing. And the messages are consistent, are clear. Number 1 is that there's an increase in prevalence in non-communicable diseases, and everybody has emphasized the double burden of disease. But more critically, they've also given us a nuanced understanding of what is going on. In fact, we have a much more productive population being afflicted. And secondly, in a situation where you don't have a social protection floor, people will have to pay out of pocket. And if you recall, one of the arguments by industry is that the poor are disproportionately affected. That is not correct, because in fact, by the time you introduce these fiscal policies, it has to reduce consumption. And that's why I now move to the rationale for these fiscal policies. Let me emphasize that The primary rationale for introducing pro-health taxes from alcohol, tobacco to sugar-sweetened beverages is to reduce consumption so that we can begin to reduce the prevalence that has been so eloquently articulated by our consultants, especially in today's webinar. The primary reason for this fiscal policy is to reduce consumption. And if that is the primary reason, it means then that the rates that you put on this tax must be significant. Right now, I give the example of the rate on the sugar-sweetened beverages, which is a great step by the government of Nigeria, 10 naira per liter. That translates into 2.50 naira on a bottle of Coke. I can tell you that the price of Coca-Cola will not increase at that rate because the company will simply absorb it. So whilst this is a first step in the right direction, a huge window of opportunity introducing this tax, we need to continue our advocacy that government needs to increase the rates because it is that increase in rates that will allow for the reduction in consumption. I just would like to emphasize that. And look, like Dr. Oko mentioned, as of 2018, Nigeria had some of the lowest taxes in alcohol and tobacco. Even though it was increased in 2018, there was meant to be a gradual and phased increase. But what happened? When COVID hit, the industry sought for a moratorium on that phased increase. So I again would like to put on the table that stakeholders, advocates on this call, we should begin to interrogate some of these implementation arrangements where we advocate for increase in the rates, for a commencement in the gradual phasing increase in the other taxes that had been introduced previously, like alcohol and tobacco. And on the other hand, we need to also, like everyone on these last three webinars have said, if the health sector will bear the brunt of the effect of the consequences. Look, a lot of Nigerians are suffering from the consequences of hypertension. You have stroke, you have chronic renal disease, amongst others. Then it makes sense that perhaps government of Nigeria should consider earmarking in the health sector. I mean, so all said and done, to the team at Nigeria Health Watch and all of the partner organizations that have supported these three webinars, I do hope we have been able to bring together a number of arguments. As you can see, even some of the questions that have come on board here, where people are questioning the data and the evidence, which the industry is saying, no, we cannot agree with the data and evidence. I hope that by some of the presentations and discussions today, I do hope that querying or doubting the scientific evidence and data will be put to bed. So I would like to end by saying people should check out the story of Philippines. Philippines introduced the Sin Tax Law, STL, and the STL was able to support Philippines to achieve universal health coverage. UHC is a stated aspiration of the Nigeria health system, and perhaps this introduction of pro-health taxes, if prioritized for use in the health sector, can perhaps initiate Nigeria's journey towards universal health coverage. On this note, I would like to just thank everyone, and Vivian will still be coming back to you to work with you and your team to still make sure that this webinar stays alive and active. Back to you, and bye for now.
Thank you ever so much, Dr. Kunala, for really summarizing the three webinar series that we've had. And as Dr. Kunala mentioned, we want to keep the discussions going. This doesn't end today. I think a lot of our panelists outlined the strong evidence and argument for pro-health taxes. given the rise in prevalence of NCDs. As a team, Nigeria Health Watch, we are always happy to have a great lineup of panelists and speakers, but also attendees who really have stayed with us this afternoon. Subsequent to this webinar, we will be sharing the recording. I know some of you have requested, as well as a presentation that was given at the very beginning. I think there's a lot of data and insights that can be used as further evidence for this advocacy that we're currently carrying out. So without further ado, on behalf of my team, Nigeria Health Watch, and the partners, National Action for Sugar Reduction, Health Federation of Nigeria, and of course, the Nigerian Cancer Society, thank you ever so much for joining us this afternoon. And we look forward to continued discussions with all of you Nigerians on this very, very important issue of NCDs and the need to ensure we have policies in place to protect the health of all Nigerians, irrespective of where they live and who they are. So good afternoon, everybody, and wish you all a very pleasant day. Over.